marrow transplant in Egypt. That was at 2003. And they do bone marrow transplant each year for about 300 cases. Um, I would like to welcome Dr. George Soriel and Dr. Muhammad Khalaf. They are the leading pioneers of bone marrow transplant in Egypt.
Welcome, welcome, and thank you, Dr. Manar, for helping put this together, and thanks, Dr. Khalaf and Dr. Soriel, for joining us. We look forward to continue this collaboration and our educational discussions to proceed. And of course, thank you to Dr. Assam, who is our presenter of the case for discussion today.
So, Dr. Assam, can you share the screen now?
I just want to make sure that we have, the pathology on the case, is there pathology presenters? Because
Oh, not for today, unfortunately.
okay. And we also don't have our pathologists on the board, so I think we should be fine. So if you would like to have like a formal start, since we if you would like, Dr. Manar and Dr. Mustafa, if you would like to have a formal start now, we can go ahead.
Hey, Dr. Mustafa, you can start.
Okay. Yeah, 1 second. Hi, everyone. Thank you for joining us today for this interesting session about the case of refractory non-Hodgkin lymphoma, where we will emphasize the challenges and the management. Today, we'll be learning like current definition and classification of refractory non-Hodgkin lymphoma. We'll review therapeutic options and decision-making pathways. We'll also discuss imaging data and clinical trial opportunities. We'll address the practical consideration and multidisciplinary management. So we have our speakers today from Egypt and from USA. From Egypt, we have the presenter, Dr. Isam Khater, who is a clinical hematologist, a specialist at Al-Maadi Armed Forces Medical Compound Hospital. And we have attending Dr. George Soriel, who is a professor of clinical hematology and bone marrow transplant at Maadi Armed Force Hospital, and Dr. Muhammad Khalaf, who is a professor of hematology and bone marrow transplant at Maadi Armed Force Hospital. Also, Dr. Manar Hamid, who is a consultant at Mansoura University Hospital. We also have Dr. Muhammad Nasr. He is a professor of hematology and bone marrow transplant at Mansoura Hospital. And from US, we have Dr. Muhammad Higazi. He is the chief of blood cancer transplant. He is associate professor of medicine at University of Louisville. And we have Dr. Robert Emmons, professor of medicine at University of Louisville. We have Dr. Sameh Gaballa, associate professor of hematology oncology at Moffitt Cancer Center. I think I present everyone. I'm not sure if the rest was not able to make it today, unfortunately. So without further ado, I will let Dr. Isam Khater start his presentation. Then after presentation, we'll have discussion point after his presentation. Okay, go ahead, Dr. Isam.
Excuse me, Dr. Assam. I'd like to thank all of organizers to give us a chance to join this meeting. It's a pleasure for me to join. I hope it's of value for all. Excuse me, Dr. Assam. Thank you, Dr. Manar, Dr. Mustafa, for your presentation, actually.
Thank you.
Thank you, Dr. George. Dr. Assam, if you can put it in presentation mode, so the slides are a little bigger. We can't hear you if you're speaking, Dr. Assam. Can anyone hear Dr. Assam speaking, or is it just me?
No, I can't hear.
You hear me?
Yes,
Yes.
now.
Yes. Welcome,
Can
Dr.
you make
Assam.
me the host, Dr. Manar?
What?
Yes, we can hear you. Go ahead, Dr. Assam.
Can you see the presentation?
Yes.
Yes.
Okay. First of all, we have Dr. Muhammad Khalaf, our professor and our consultant at Mahdi Armed Forces Medical Military Complex. I can't start without permission from Dr. Khalaf. So,
Good afternoon, everybody.
Sir.
Yeah, okay. Good afternoon, everybody. It's an honor for us to have this excellent gathering from Egypt and US. So, Dr. Assam will present an interesting case for discussion. Please, Dr. Assam, go ahead.
Thank you, sir. We have Dr. George. Thank you, sir. Now we can start our presentation. It's a privilege for me to speak to such interested and motivated doctors telling such a story of a case at our place, Mahdi Armed Forces Medical Military Compound. It's a case of, this is a pre-referral history. August 2018, 55-year-old female patient with left hypochondrial pain. Ban CT is done and shows splenomegaly with splenic focal lesions. Splenectomy done at the place where she was treated. It shows splenic marginal zone lymphoma. Diagnostic workup at this time show normal CBC, normal liver functions, normal renal function tests. Virology was negative regarding hepatitis B surface antigen, HCV antibody, and HIV antibody. Uric acid was 2, LDH was high. Radiological assessment show multiple enlarged lymph nodes with largest at retroperitoneal area show 4 by 5 centimeters. Bone marrow aspirate was hypercellular with no infiltration. Echo was normal. Splenectomy show marginal zone lymphoma. So the diagnosis was splenic marginal zone lymphoma. Then she was on wait and watch protocol from August 2018 till November 2018. She presented to us at November 2018 with toxic symptoms in the form of night sweat, increased lymph node size, clinical progression in cervical and axillary regions. We go for biopsy, show marginal zone lymphoma. Ban CT is done and show porta hepatis lymph node 6 by 5 centimeters. So there was an indication to start treatment in regarding bulky lymph node size at porta hepatis. We go for CVB as a debulking, then for Archo protocol for 3 cycles. Interim assessment show regressive course. We completed 6 cycles and go on our follow-up protocol every 3 months. We go for radiological and laboratory assessment with pan CTs with contrast. And it was in CR till May 2019. She had an abdominal pain. Ultrasound show uterine mass 9 by 8 centimeters. Total abdominal hysterectomy and bilateral salpingo-oophorectomy done. And pathological evaluation show diffuse large B-cell lymphoma, active B cells. It was positive for CD20 and MOM1 and negative for CD10 and BCL6. Ban CTs at this time show para-aortic lymph node 3 centimeters, cervical and axillary 2 by 1.5 centimeters. We go for DHB protocol or DHAP for 3 cycles from January 2020 till April 2020. At this time, the patient after 3 cycles developed right facial swelling. CT show chronic bilateral ethmoidal sinusitis. After 3 cycles, there is a mixed response, regression of cervical and axillary lymph nodes, but with newly developed lesions at right submandibular area and parotid lesions. SUV max was 10, and lung cavitary region with air fluid level 6 by 5 centimeters, SUV 4. Regarding this mixed response, we completed the RDHB protocol for another 2 cycles, completed 5, and we did MRI brain at no abnormality detected, and MRI paranasal sinuses show chronic bilateral ethmoidal sinusitis. At September 2020, we did PET-CT, it show regressive course, regression of parotid and submandibular lymph nodes. SV max 5, it was 10. stable lung cavitary lesion, 5 by 4 centimeters, SUV max 3. And the patient refused to go for autologous transplant. And we did a committee at our place regarding this mixed response assessment. And we decided to go for local radiotherapy on residuals. I mean parotid and mediastinal lymph nodes. Then to go for 2 cycles of R-Vigamox protocol. But the patient developed a sudden elevation of liver enzymes. And we did a virological evaluation by ELISA. It was positive, so we go for PCR assessment. It showed hepatitis B, active hepatitis B, and active hepatitis C. So our plan was changed. We go for local radio on parotid and mediastinal lymph node as residuals, and active treatment of active hepatitis, and 2 cycles of Vigamox protocol, and we avoid using the rituximab. Then we did assessment following the local radiotherapy and Vigamox 2 cycles protocol. We show complete remission, but the patient was having an chest infection. As we mentioned, there is a cavitary lung lesion. We did a COVID-19 assessment by PCR, and it was positive. From March 2021 till September 2021, we avoid not using a treatment as we are on active treatment for COVID-19. After this, we go for evaluation for this patient. At January 2022, we see a progression, multiple enlarged lymph nodes with multiple activities. It was at cervical, axillary, inguinal, and right thyroid nodule. We go for biopsy from right axillary lymph node. It showed diffuse large active B cell. At this time, we did BCL2 assessment on the lymph node biopsy. It was 45%. Our committee to give Vigamox another 3 cycles, but at this time we wanted to add venetoclax as a BCL2 inhibitor. We did 3 cycles of this protocol, Vigamox plus venetoclax. And we did assessment by PET-CT at April 2022. It showed complete remission, but 3 weeks later, the patient developed the right orbital swelling. MRI done and show right outer orbital soft tissue. It was 2.5 by 1.2 centimeters, and right cheek diffuse swelling, subcutaneous edema, 5 by 2 centimeters. Our committee to go for 1 more cycle of Vigamox plus venetoclax and the pre-autologous transplant workup. But after this cycle, we did assessment. PET-CT show progression. The patient was clinically having a chest infection, and this delays the time in between the cycles. After this 4th cycle, we did assessment at September 2022 and show progression. PET-CT newly developed region at cervical and the hilar region. So we exhausted a lot of many treatment protocols. So we go for RLI protocol, rituximab plus lenalidomide plus ibrutinib for 3 cycles, and we did PET-CT. It shows stationary course. At this time, we did PCR for hepatitis B and hepatitis C, and they were negative. We give another 3 cycles, and it show PET-CT show CR. Respiratory function tests as an assessment before autologous transplant shows severe restriction, and the patient also refused to go for autologous transplant. And we continue till now on RLI protocol starting from September 2022 till now. She is on RLI protocol, and her disease status was in complete remission. This is our case. And our take-home message: collaborate and coordinate. And if you change nothing, nothing will change. And thank you.
All right. So excellent presentation. I'm sure the panelists have some questions, but I had to really excellent job on putting this presentation together and the case together. Just for those who are not familiar with RLI, it's Rituxan, lenalidomide, and ibrutinib. Is the patient has been on since September of 2022. until now, correct, Dr. Assam?
Correct.
And the BCL2, that was an immunohistochemistry expression. So that was on the immunohistochemistry staining is the BCL2 that you look for, right? Not molecular BCL2 rearrangement.
Not molecular. It was an immunohistochemistry.
It was in immunohistochemistry. Okay. All right. Okay. So did we look for FISH to see if this patient has MEK or BCL2 rearrangement?
We can load the MEK. It was not available at our place.
Got it. Got it.
And additionally, excuse me, the issue is the double hit is a bit uncommon if you have the ABC type. So most of the majority, I'm afraid to say, of the double hit is actually should be of germinal center. And this patient actually start with a splenic marginal zone, which is usually post-germinal. And when the transformation did happen, it was activated B cell type. So this is very unlikely to be double hit. Plus, what this
about 20.
some describes that having the translocation by fish is not routinely available.
Got it. Got it. Yeah, it's only about, I think, 20% of the time that activated B cell would be also a double hit. But that is very correct. Thank you for chiming in. So, questions from the team? Dr. Babullah, Dr. Emmons?
So, go ahead.
Sorry.
No, go ahead, Dr. Emmons.
Sure. So the first question is, hepatitis B and C became active seemingly in 2020, which is interesting given that the patient had received significant Rituxan before. Was there no inkling of hepatitis prior to 2020?
Yeah, it was actually tested negative by serology at the time of presentation, but probably this was not an accurate measure because it seems that this patient had both occult B and occult C, and it has been reactivated by the heavy chemotherapy and immunosuppressive therapy. So it seems that the patient actually had occult B and occult C. And we actually were facing this issue in the past quite very commonly.
And we're sure that it is in fact hepatitis, both B and C. Is that correct?
Yeah, it's what by PCR. Yeah.
Got it. Okay. Then the patient in 2020 developed sinusitis and a cavitary lesion in the lung. The presumption, I guess, is that this may have been related to lymphoma, but the patient was significantly immunosuppressed. Do we know if there was any inkling of a mold infection in the background here?
Yeah, I don't remember exactly. Maybe Dr. Assam will remind me.
No, actually, this cavitary lesion was radiological assessment, and cardiothoracic doctor revealed hiatus hernia. Actually, it's not an abscess or lymphomatous issue. Maybe Dr. Assam missing to say she actually had hiatus hernia, and part of the stomach was in the chest actually.
Yeah.
Which is very, very strange actually.
So it was a hiatal hernia, not a cavitary lung lesion. Is that what I'm hearing?
No, not a cavitary like an abscess or tissue like lymphomatous infiltration. It was related to hiatus hernia. Some of the intestine, or actually the stomach, was in the penetrated diaphragm and was in the chest actually.
Okay. Also, when the patient first presented in August of 2018, the LDH, as I understand it, was quite high at 1,193, which would be distinctly unusual for a marginal zone lymphoma. Did the pathology from the spleen contain a large cell component, or was there any evidence of large cell lymphoma at that time?
No. From August 2018 till January 2020, we revised the pathology and we did 2 biopsies, and the 2 biopsies are revised, and it show marginal zone lymphoma with no persons of large cell transformation or large cell at the pathology.
I see.
So large cell were recognized at January 2020.
Yes, in spite of LDH is very high actually at presentation, which is not common with marginal zone.
Yeah.
But the patient, as Dr. Assam said, was actually treated outside our hospital, and the pathology was marginal zone, and we revised it with our pathologist in our hospital and revealed marginal zone. And you cannot say this when cyst this is a large, and you are fault because we two pathologists or two group of pathologists confirm the same diagnosis at the same time.
Yeah. May I ask a question? Was there a PET scan done at the staging, or was it only a CT scan?
The first PET-CT done at September 2020.
Oh, okay, so that was after she was treated.
Yeah.
Yeah. So Dr. Emmons, so and everybody, I think what was going on here is, she presented with transform disease, but mostly probably it was in this porta hepatis lymph node, which was the largest lymph node, 6 centimeters. And if you go back, maybe bring up the slide of the initial presentation, or no, actually, no, this one has the summary too. If you look at the, so she came in, symptomatic in 2018 in August. And then, between August and November, she started to have, rapidly, new symptoms and, changing on images and stuff. So, this by itself would be a clinical diagnosis of transformed disease, regardless of what the biopsy said. I mean, the good thing is they actually started with treatment as if it's transformed disease with R-CHOP, and did not treat it as an indolent lymphoma, which was the, absolutely, I would have definitely done that as well. But a lot of time you biopsy one spot, but these transformed diseases, it's not like you're going to see the large cell lymphoma everywhere. Typically what happens is you will have transformation in only a few spots, and this is where the PET scan is usually helpful at screening. So I'm assuming if we would have done a PET CT scan at presentation, you would have found that those, maybe the porta hepatis lymph nodes, the SUVs would probably have been like, 20 or above, but everything else would have been like, 6, 7. So the transformation does not typically happen in all the, in all the lymph nodes at once. And that's why it's important to, put the clinical presentation in perspective as well. So it's not usual for a marginal zone lymphoma just to watch it for 2 months or 3 months and then start, developing, new symptoms and new problems and the very high LDH and bulky lymph nodes and fevers and B symptoms. All these are, all these are suggesting that this indeed was transformation at the beginning.
Actually, you are completely right. It could be large cell lymphoma from the start, and what we took out as a biopsy, which was a spleen, it doesn't take a lot of uptake. If we did actually PET scan at this time, it could we can find other lymph nodes with high uptake, as you said. It could be taken as a biopsy, and it may reveal large cell lymphoma, but actually we did PET scan at presentation. It could be maybe of value to discover this is a large cell from the start, but we depend on the pathology and revise it again. But it was missing actually. You're right.
Yeah, and again, I mean, I'm not saying that the splenic biopsy did not show, a splenic. I mean, I'm, so probably what's going on is the splenic lesions were indeed splenic marginal zone lymphoma, but she probably had transformation in that, big lymph node.
And other sites, yes.
Yeah, exactly.
Yeah.
The other thing too, the other thing to consider too is I know that she wasn't treated with you, initially, but one of the things is, we try to preserve the spleen. So if someone is coming in with, splenic lesions and multiple lymph nodes, I mean, we could have probably gotten the lymph node, the diagnosis from one of the lymph node biopsies, or the bone marrow is typically involved in splenic marginal zone lymphoma. So a bone marrow biopsy at the beginning would have probably also shown a splenic marginal zone lymphoma, and try to preserve the spleen, because now the patient is going to be immunosuppressed on the long run. She'll need to be probably on lifelong Bactrim prophylaxis, which is in Egypt, it's the the sulfamethoxazole trimethoprim, prophylaxis, because they could get overwhelming pneumococcal infections after a splenectomy. But the interesting thing, I mean, we could move on to the case discussion about what to do now. This unfortunately is one of those situations where you get rapid relapse of diffuse large B-cell lymphoma in less than a year after transplant. I'm sorry, after R-CHOP, and those patients, typically in the era of rituximab, they will not have long-term remissions or the disease control with chemotherapy followed by an autologous transplant. So if you look, for example, at the CORAL study, where they looked at DHAB versus rice followed by transplant, and this was in the rituximab era. The patients who've had rituximab and relapsed less than a year out, those are especially less than 6 months out, those are the patients that only the survival was only about 15%, or I'm sorry, the PFS was only about 15% long term with salvage chemotherapy and autologous transplant. So for those cases, we try to, they're typically chemorefractory, as in this case, she's seen multiple chemotherapies. And for those are the cases where, CAR T-cell therapy or a bispecific antibody might make a lot of sense. I know that those are probably not in Egypt, I'm assuming, but I really like the approach of a non-chemotherapy approach with rituximab, lenalidomide, ibrutinib, because doing more chemotherapy is not going to be helpful, and even if you try to do an autologous transplant, it's probably not going to benefit you a lot, because again, the patient has already demonstrated that they're chemorefractory, and autologous transplant is really just it's basically just more chemotherapy. I mean, you might, I don't know what, everybody would think about like a non-conventional approach of trying like an allo transplant, but I typically don't like an allo in this situation. But if there's no availability of CAR T or bispecifics or, other novel agents, I mean, this is one thing to consider. But again, this is this is not a good situation, and the patient will probably relapse again within a year or less, and the prognosis is typically not good in this situation.
I believe the statement was made earlier that the original marrow was negative. Correct me if I'm wrong. Also, the restrictive lung disease I heard was significant. Is that correct, as far as considerations of allo transplant, not to mention the underlying liver disease, which is a little worrisome from both hepatitis B and C? These would certainly make it more difficult to consider allo transplant for a patient like this. I think there are other options to consider short of bites and CARs. I don't know how available these are in Egypt. I mean, it sounds like the Rituxan, lenalidomide, ibrutinib is working for now, but there is tafasitamab, lenalidomide, selinexor has been used in this circumstance. There's loncastuximab, tesirine, and then combinations of things like polatuzumab, bendamustine, Rituxan have been used for these sort of situations as well. So those would be non-immune T-cell immunologic harnessing therapies that might be tried if this patient starts failing this other regimen.
These are excellent points. I have a question. Since the total abdominal hysterectomy in BSO back in 2020, when was the next biopsy done?
Dr. Assam, you remember?
Yes, sir. It was January 2022.
2022. And that was after our DHAP, or
Yeah.
and before the okay, I guess between the VGemox and the venetoclax VGemox.
Yeah.
And it was still DLBCL all along. Okay, so the idea in my mind is that are we looking at areas that might be still the untransformed marginal zone that is where maybe successful right now, and the chemotherapy maybe succeeded in the DLBCL component, but not necessarily in the marginal zone. But it was the last biopsy was with VGemox, but before the venetoclax with VGemox, and since then the patient had an assessment with a PET scan that showed progression and was put on RLI, which has been very successful since then, which we don't want to mess with the success. It's an expensive regimen, but it's working, so we can't argue. I just wonder in my mind is this indeed DLBCL responding, or parts of what we are seeing is also the marginal zone is responding, because we know marginal zone maybe will do better with BTK inhibitor, as well as with the Revlimid than DLBCL does. But this is there's nothing of the novel therapies that is mentioned that I will add extra to. These are amazing therapies that have transformed the field, but leveling the ground is right now it's a successful treatment with RLI, and the point is we'll see how things go. Has the patient had any scans since that last scan back in June of 2023?
Yeah, she has a regular assessment every 6 months. We did CTs, band CTs for the first year since 2023. We did the BIT CT 2 times, and now every 6 months we did the CT assessment with contrast, band CTs with contrast.
Excellent, and it's all been continued CR since then.
She has continued CR, and my question: what if we lost our success with RLI protocol? What we can do if we lost our success with RLI? Is there any other option to do?
Yeah, so the question is what's available in Egypt? Like, for example, you have, polatuzumab, loncastuximab, tafasitamab, I don't know, maybe bispecific antibodies. I'm not sure. So what are the available tools?
Unfortunately, none of these options are available.
Yes.
Neither the bispecifics nor the CAR-T. That's why we think of the RLI for short, using autologous transplant, and we have no other options. So it would be a problem actually if we lose the response with RLI. Maybe at that time we can discuss reduced intensity allogeneic transplant. Also, I'm afraid the comorbidities she has will permit or she will accept.
Would she tolerate like an autologous transplant now?
No. We were suggesting autologous transplant. Actually, it was not a definitive treatment. We were planning to have some high-dose chemotherapy debulking because we knew that this patient is quite chemorefractory, but to be followed by some immune manipulation like the RLI as a maintenance therapy post-auto. But she actually refused the transplant at 2 time points. Hopefully, this response will continue, but in case she lost the response, I hope we can pick up the disease recurrence a bit early so as to allow for some salvage therapy to be followed by reduced intensity allo. This is what we can afford and can we deliver in Egypt, because we hope the bispecifics will be soon in Egypt, CAR-T hopefully on the horizon. But at the moment, we don't have access to these two policies.
And not even polatuzumab or tafasitamab?
Yeah, Pola is available, but personally, I'm not very convinced that Pola will have a magic difference from others. But of course, it will be it's available and it can be on the list. But having Pola alone, or probably you are right. Probably we can salvage her with Pola and Benta because she had no exposure to bendamustine so far. So probably this may get her into a no remission, but ultimately she has to receive more definitive therapy, either bispecifics or CAR-T or reduced intensity allo.
There's another feature that needs to be borne in mind, and that is that this patient developed an orbital mass in April of 2022 and has had a long history now of resistant large cell lymphoma. She also had a uterine mass. All these things put her at higher risk for central nervous system disease, and some potential prophylaxis might be considered for somebody who's such high risk.
Excuse me, would you raise your voice?
I'm sorry, was I not able to be heard?
Yeah, it was a bit low.
I'm sorry. Okay, I'll say it again. Given the longevity of her resistant large cell lymphoma, the presence of an orbital mass as of April of 2022, and a uterine mass previously, which was removed surgically, she's at higher risk for central nervous system disease, and potentially prophylaxis might be considered in this patient.
Yeah. You are absolutely correct. Yeah. It's a good point.
But
Thank
the
you.
good thing that she's receiving ibrutinib, which can close the blood-brain barrier. Am I right?
That is correct.
but
Of
actually-
the BTK inhibitors, it is the best to cross. However, ibrutinib of itself would be considered likely insufficient therapy for large cell lymphoma of the central nervous system.
Yeah, and this is in addition to we are not giving continuous therapy with ibrutinib. We are just giving every cycle just 10 to 15 days. So we cannot rely on ibrutinib alone. So it's a good point to have some CNS prophylaxis in addition to the possibility of having ibrutinib crossing the blood-brain barrier. So it's a good point. Thank you.
And again, autologous transplant at this point, notwithstanding the lung disease, would also be tremendously difficult to harvest stem cells given the type of therapy she's received for so many years. So I think it's unlikely that she would do well with an autologous transplant, even if she consented to that currently.
Yeah, I agree, but I think if she if she does relapse, we will probably try to give reduced intensity allo because you are correct. We probably will not be able to collect enough autologous stem cells. So it's really chemorefractory patients, and she is responding to some immune manipulation. So it seems that if she relapses and she are lucky to have another remission, we can consolidate this remission with some allogeneic procedure.
Has she had another bone marrow biopsy since the one in 2018 ever?
No.
No, in like CAR-T is maybe the best, has the highest promise. Is there any way that patients who, like, I guess there will have to be some financial means that they can go to a neighboring country? You know, I had the pleasure to be at the annual conference of Mansoura University last month, and I heard from some of the speakers that now Jordan is doing CAR-T, and potentially Lebanon is bringing CAR-T as well. I guess
And
it's
Saudi Arabia as well.
And Saudi Arabia. Is that something that patients, if it's not yet in the horizon in Egypt, and I hope that it will be in the near future available, that they can travel to get such therapy with Lysocell or Axicell or any of the CAR-T products that they have available to be, because reduced intensity is the answer if you don't have any other options, and it may have with the immune reconstitution some continued remission there. It's guarded with a ton of toxicity in a patient who has a restrictive lung disease and all what she has been through. But I'm just trying to think of, is it possible to kind of get her CAR T somewhere else if that's not
Yeah,
possible?
I hope CAR T will be available before she relapses. But so far, if she relapses now, there is an issue, a financial issue, even in sending patients to neighboring countries for CAR T. It seems also it will not be affordable from the financial point of view. So what we are looking for is to have local manufacture of CAR T and having this procedure a bit affordable for the Egyptians. So I don't think that we can send all patients who are eligible for CAR T and refractory to standard therapies to any neighboring country because, again, this would be a financial burden.
Given the current economic reality for the use of CAR T worldwide, there are clinical trials now for the in vivo production of CAR cells using injected retroviral constructs as a clinical trial. You might reach out to the centers that are doing this currently, Seattle, for example, to see if they would be interested in an international collaborator site, because that would obviously change the logistics and ability to do such therapy locally significantly.
Yeah, I think the in vivo expansion of CARs would be more suitable for our economy. Yeah.
Do you understand what I'm saying by in vivo CAR?
Yeah.
Okay, gotcha.
Okay, so I have more discussion points. Dr. Assam, can you unshare your screen, please? Dr. Assam?
Dr. Assam?
Yeah.
Unshare your
Share,
screen.
please.
Okay. I think now it is unshared.
Still shared.
Not yet.
Not yet.
The other person may need to stop sharing for yours to display. There you go.
Okay, now?
Yeah. Can you see my screen?
We can.
Yeah, yeah.
Mhm. So let's start with this RLI regimen. I don't use it routinely in my clinic, so it was interesting to look at the evidence behind it. So it was first tested in the relapsed non-germinal center diffuse large B cell, and it showed the PFS of 5.5 months. Interestingly, it was combined with chemotherapy in the line and the Smart Start trial, and it showed a magnificent overall response rate. Overall response rate was 100%, with CR rate was 95%. But all I could think about is the toxicity, especially neutropenia, when you combine rituximab with lenalidomide with ibrutinib with R-CHOP. So, do you support the combination chemotherapy plus RLI, and do you recommend using it in your practice?
Again, in this country, with competing BiTE and CAR T therapy taking the forefront for such resistant patients, we rarely have the need to consider such options, especially given the other potentials, as we mentioned, tafasitamab, loncastuimab, polatuzumab, and so on, which have had other more promising clinical trials, at least in this country and in Europe.
So this regimen also has an established role in relapsed mantle cell lymphomas. The long-term follow-up of the Philomen trial was published 3 months ago, and it showed the PFS of 17.4 months, which is not bad for this category of patients. And this combination with R-CHOP reminded me of combining ibrutinib with R-CHOP that the Phoenix phase 3 trial. It didn't show any improvement in the event-free survival in the intention to treat population, but when they did subgroup analysis in the double hit, the BCL2 MYC co-expressors, it showed the improvement in the event-free survival. And when lenalidomide was combined with R-CHOP alone, in the phase 2 trial, it had promising results, but in the phase 3 trial, it was negative. Okay, so the second point is, in November 2024, we
Can I
witnessed
interrupt you, please, for this regarding the adding ibrutinib and lenalidomide to R-CHOP? The problem is that we were looking for the benefit for adding something to R-CHOP in the whole population of the LBCL. But when subset analysis for the Phoenix study showed that a particular subgroups of patients either having MCD subtype have excellent, although the group of these patients were actually not too big, but the response, the outcome was quite different with the addition of ibrutinib. In addition, also, if you look for the age effect of on the ibrutinib R-CHOP arm versus R-CHOP, so patients who are younger than 60 or 65 would actually derive some significant benefit from the addition of ibrutinib. So it seems that the toxicity of adding ibrutinib to the whole population had nullified the effect of adding or the benefit of adding ibrutinib to the young patients. The same with adding lenalidomide. Actually, if you look for the group of patients with the ABC, they derive a higher benefit compared to the whole population. So it seems that if we add something to R-CHOP, we have to be very careful in looking which subgroup of this very heterogeneous disorders of the LBCL will have the greatest benefit.
Okay, thank you, Professor Mohammed. So the second point is the GMOX regimen for relapsed refractory diffuse large B-cell. So in the STARGLO trial, it showed magnificent improvement in the overall survival, doubling actually the median overall survival was 25.5 versus 13 months. So also the epicortamab, the other CD25, showed promising result in the EPCOR NHL2 trial. So do you think now that the monoclonal CD20 antibody are going to be replaced by the CD20 bites in the near future? Are we going to see regimens like glue shop or epicort shop to be the standard first line regimen?
So the randomized trials are ongoing, but if I had to guess, I would guess that yes, bispecifics will make it to the front line. But again, we just have to see how that compares to to standard frontline R-CHOP, and if there's a benefit, because yes, the trials you showed with Revlimid and ibrutinib, yes, maybe there's like some subgroup analysis of some groups benefiting, but again, these are not pre-planned statistical endpoints, so the studies are negative. So that's why ibrutinib or lenalidomide are still not in the used in the frontline setting. But I personally think it's probably bispecifics will be the new standard of care in the first line, but we'll just have to see how that compares to R-CHOP, because beating R-CHOP has always been a challenge historically. And the only recent addition was the Pola R-CHOP, but that was like after more than 20 years of trying to find to improve on R-CHOPs. It's always very tricky, but we'll see. The phase 3 trials are ongoing. There's also trials ongoing in indolent lymphomas in the first and second line setting. So they're making very quick moves with bispecifics in non-Hodgkin's lymphoma.
Yeah, and maybe it will be used like a maintenance after induction with R-CHOP.
Well, the problem is, so the problem is if you look at so there's two different philosophies here. So epcoritamab, they came out with, in diffuse large B-cell lymphoma, at least initially, with a kind of like treatment till disease progression, whereas glofitamab, they went with a time-limited approach for only 12 cycles. And mosunetuzumab also went for a time-limited therapy, at least in follicular lymphoma. But now, if you look at the most recent updates, last ASH from the epcoritamab long term, no, there's significant, infectious mortality specifically from, infections and COVID-19. So I don't think, I think the time limited option is certainly, the way to go here. Aggressive lymphomas in general are curable diseases. So you typically don't need maintenance therapy. Maintenance therapy is usually helpful in things, like indolent diseases that are not going to be cured. And if you keep on using maintenance with a bispecific as an epcoritamab, you're going to start seeing a lot of, infectious problems. And again, it's not like maintenance rituximab. Maintenance rituximab is just an anti-CD20, but if you think about it with a bispecific, you are depleting the B cells with, whether it's CD20 or some of the newer targets are targeting CD19 and whatnot, like AZD0486. But the bispecifics are also tiring out and exhausting the T cells because it's continuously engaging with the T cells. So it causes T cell exhaustion. And on the long term, that will lead to have a T cell, immunity problem as well as a B cell immunity problem. So the infectious complications are higher with bispecifics compared to the other agents that we have.
So,
in terms of
okay.
who wins, which was your question, the garden variety low risk large cell lymphoma patient will have a hard time justifying the use of more toxic agents anytime soon. The success rate with R-CHOP has just been so great. The POLA R-CHIP, for example, really only showed on subset analysis to be a benefit to the activated B presentation patients, not to the germinal centers. And again, germinal center, large cell, non-double hit, the widest number of patients that present, do extremely well with R-CHOP in the modern age. So it's going to be a very hard justification to give other more toxic regimens.
So I have another question. When you have ibuprofen and glofitamab both present in the pharmacy, what are the criteria that guide your decision when do you decide to give ibuprofen, not glofitamab, or the other way around?
So I could tell you from our experience with both products, we look at them quite similarly in terms of like, okay, they're both bispecific CD20, CD3. When we had our bottom line, it was all regarding to, is there any clinical benefit that makes you continue on a continuous treatment with epcoritamab over a time-limited therapy that Dr. Gaballa just alluded to? And the answer is indeed not really, but there is more toxicity, let alone the difference in cost and the financial toxicity of a continuous treatment. So as a center, we are more of a glofitamab on, of course, that's like if the patient is not joining on a clinical trial or anything like that, it is glofitamab, the bispecific between the two that we would choose. I don't know what Dr. Gaballa at Moffitt uses in commercial.
Oh, sorry, I was on mute. So it's a good question. There's some differences between them. I mean, in terms of efficacy and toxicity, I think they're very similar in terms of response rates and CRS levels and other toxicities. But there are some differences. So epcoritamab is subcutaneous, so it's quicker and easier, but it is more frequent administration. So it's once weekly, at least initially for the first 3 cycles, which is more frequent visits to the hospital. Glofitamab is an intravenous infusion, but it's less frequent. It's every initially, obviously, you get day 8 and day 15, but then afterwards it's every 3 weeks. So, I typically actually, I usually have I personally prefer just like, to bring the patients less frequent. So I typically prefer glufidamab. And the other thing I do prefer with glufidamab is that it's a time limited therapy. I don't think, patients with diffuse large B-cell lymphoma need a maintenance schema. So I personally usually prefer glufidamab for these reasons. I've had a patient with follicular lymphoma who did not want to do IV infusions and preferred the subcutaneous, so she's getting epcoritamab for that reason. But again, we're not doing it indefinitely. We're also doing a time-limited therapy with her follicular lymphoma.
I guess there is no big difference between the two because it seems that the differences are actually related to the study design in each drug. So there is no biologic difference to justify maintenance therapy with EPCOR versus GLOFI. So at the end of the day, I would expect both will be used interchangeably and for the same protocol. So this may be related to the study design, not because of a particular feature in GLOFI versus EPCOR.
Okay, thank you, professors. So let's move on to another point. So recently, in the recent update of the NCCN guideline, we have seen this category 2B recommendation of the use of ctDNA as a way to measure MRD in diffuse large B lymphoma cases who still have positive PET-CT after induction chemotherapy. And if the biopsy is not accessible, then you can go and do a ctDNA test with a sensitivity of detection less than 1 ppm. And if it is negative, then you consider the patient in CR. If it is positive, I don't know. If it is positive, do we treat the patient as primary refractory and go for CAR-T or something? Or what do we do?
So you mean if the ctDNA is positive but the PET is negative, or the PET is also positive?
Okay. I want to know what you think in the two situations.
Oh, okay. Yeah, so if the PET is positive, it also depends on, what do you mean by positive? If it's just like a, Duval score of 4, or, maybe a Duval score of 5, but there was a significant reduction in the, SUV by more than 70% or so, I think this is where you have two options. You could either do a ctDNA, and if that is also positive, then probably the positive PET is real. And yes, you would treat this patient as a refractory. Obviously, the gold standard is a biopsy. So if there's an accessible lymph node, you biopsy it. If there's active disease there, then yes, you go to CAR T-cell therapy or salvage therapy. But if it's negative, then no, then you keep an eye. If the PET is negative, there's no point in doing the ctDNA. Now, usually the issue would be, well, what if the PET is negative, but for some reason someone checks the ctDNA and it comes back positive? What do you do then? Well, nobody knows. I've had that situation before, or someone had a PET negative, but they still sent off a ctDNA and it came back low positive. I think in those situations you also have to look at what exactly is positive. Is it light chains? Is it heavy chains? Heavy chains are more more suggestive of residual disease. And what I've done with this patient is just repeat another ctDNA in a couple of weeks to keep an eye on it and see what happens. And instead of doing the scan in like 6 months, I'm just doing it in a short interval in 3 months, and just to confirm that there is indeed progressive disease. So what I'm trying to say is sometimes it's clear cut, meaning someone has negative disease and you're just going to do surveillance, or someone has for sure positive refractory disease and you biopsy it and it's positive. But I think the ctDNA right now is helpful in those situations where it's somewhere in the middle. You're not sure if they're like in CR, but maybe there's like some activity and you're not 100% sure. And I think this is where ctDNA might be helpful if there's no accessible spot to biopsy.
So up till now, you still go for biopsy.
But biopsy is the gold standard. Yeah, I mean, this is you. I mean, if someone has an accessible lymph node, and usually I would prefer a biopsy, yes. But again, sometimes that's not always the case, and these patients might need, like, if the biopsy might need, to be a little bit, more invasive. So then, in that situation, yes, the ctDNA would be another, tool. The and there's also, different modalities, so they're not all the same. So there's clonoSEQ, for example. There's also phased-seq, but that's not commercially available yet. There is some differences between them. I think the phased-seq is an excellent negative study, meaning that if it's negative, then this patient's probably in remission. The clonoSEQ is a better positive study, so it's more specific. But this is still evolving, and it's not widely used. But these are the situations where I personally would use them in. It's like these questions, these patients where you're kind of on the verge, you're not 100% sure if they're in remission or not.
In your patient, this is complicated by the fact that the original disease was marginal zone lymphoma, which may never be cured and will always have a background clonoSEQ signal that may not have anything to do with the large cell component. Hence, biopsying masses of high SUV will be critical to decide whether it's a relapse that is, in fact, large cell biology or just an indolent lymphoma continuing to grow in the background.
Yeah, that's an excellent point, Dr. Emmons, because basically, what the ctDNA is looking for is just the monoclonal, the immunoglobulin variable region, and that's going to be the same in the slow-growing lymphoma. And if it's clonally related transformation, then yes, it will be the same clone, so you will pick it up. And these low-grade lymphomas are not usually curable. Although you could get ctDNA negative, indolent disease. If they're in deep remission, you're going to have, MRD negativity. But in this specific situation, your specific patient is not going to be very helpful.
Okay, this is the last one. So we have seen some conventional chemotherapy-free regimen like mosunetuzumab with a CD20 BiTE and the polatuzumab, the study drug the conjugate against CD79B. This regimen is good. It reduces PFS of 16.5 months if it is given in the second line, and less PFS benefit if it is given as a further line, especially if the patient received the prior CAR T. In your daily practice, do you use this regimen before or after CAR T? And what do you do upon progression on both CAR Ts and BiTEs?
Yeah, so I could answer this one too. So basically, we try to take these patients to CAR T. None of the other options have been compared head to head with CAR T. So there's like a lot of options, not just Mosun-Pola. So there's Mosun-Pola. There is ipcordamab with Gemox. There is glofitamab with Gemox. Just in Lugano last week, there was a presentation where they used glofitamab with loncastuximab, and it looks very, very promising. But all these combinations, we typically would reach out to them either post-CAR T failure or in this, even as early as the second line in someone who has no access to CAR T. And I think these are some of the options that might be very, they're not as expensive as, say, CAR T cell therapy. So I mean, if there's bispecific antibodies in Egypt, I would definitely do a combination like this if there is no access, to CAR T. Now, your last question, what do we do for, post CAR T and post bispecific failures? These patients do very, very poorly. Typically, we try to take them for a clinical trial. Or we try to use some of the other options that they've not seen, but the prognosis is typically not good. If you get a remission, some people would consider an allo, but a lot of these patients end up, unfortunately, dying from their disease.
Thank you so much.
Any other comments on this last point? One last thing. I would say in the Mosun is when I saw this data, it was in those patients who have very rapidly progressive disease that we're still planning to take onto CAR T. We use it as a more of like a holding/bridging treatment modality while the T cells are being manufactured. So the patient is getting that treatment temporarily until they have their CAR T ready for infusion. Because, as you know, the soonest it can be like 2 weeks, and sometimes it takes 4 weeks for the cells to come back to us for lymphodepletion and infusion. So as a bridge, but I totally agree with Dr. Gabala in terms of upon relapse after using all these novel therapies, unfortunately, the prognosis is extremely poor, and we have to look at the big picture and goals of care discussion. Dr. Emmons, any comments?
None, just what I said at the last one of these meetings, which is if you can participate in clinical trials and that can bring some of these modalities to Egypt, it would be a better way to try to do it if possible. And especially, as I mentioned, with regard to the in vivo CAR trial, which is logistically much easier to do and doesn't require ex vivo manufacturing, that would be the potentially most promising, both logistically and financially, for your center potentially.
Yeah, we can ask the Egyptian Cancer Society to try to work on that. So I will reach out to them.
I think that would be an excellent initiative, Mustafa, if the Egyptian Cancer Society can work as a link between the clinical trials that are happening in the US and see if they are interested to also collaborate with our partners like the Maadi Force, Air Force Military Hospital or University of Mansoura. That way you have these options that are definitely more logistically doable. And for our patients, if this is available, I don't know, but I think the autologous manufacturing is going to die if in vivo development of CAR T become a reality.
Yes, I think they are active right now. They were in ASCO and they had a collaboration with ASCO, so I think they will be willing to work on this. And they also are interested in our tumor board and they are sharing it. So I will reach out to them for sure.
Excellent. Thank you so much, everyone, for putting such a wonderful presentation and discussion to follow. Thank you for all the panelists, and thanks, Mustafa.
Thank you so much. See you next meeting.
Thank you very much.
Thank you.
Come on. Pleasure.
You, everybody.
Thank you very much.
Good luck and goodbye.
Bye.